I'd like to first thank Dr. Scott Levin for joining us tonight. And we're going to be talking about the complications following arthroscopic hip surgery. He might talk about labral repairs, he might talk about FAIs. Certainly, Rob and I will talk about the rehab and what to avoid and what not to do. I look forward to hearing about Dr. Levin's post-op guidelines that he sends his patients home with, and some of his surgical techniques too that differentiate surgeons. In any case, probably the most important thing with preventing complications in hip surgery patients is preventing the complication prior to the surgery. And Dr. Levin, that as you taught me, that goes back to choosing the right patient, right?
Yeah, it's a difficult enough operation to actually physically perform, but it's just as hard to making sure you're choosing the right patients that will benefit from a hip arthroscopy. And so that's the most important thing, just making sure your indications are appropriate and making sure you're operating on the right patients for sure.
When that patient comes in and says, "Doc, I got hip pain. It hurts the outside of my hip, or it hurts deep into my groin." Can you take it through your evaluation and the imaging you might do, or what special tests you might use to get that patient properly diagnosed and maybe to the OR or maybe to non-op therapy? Do you bring every patient to the operating room, or do you send some to us in physical therapy? Come on.
Yeah, I mean, unfortunately, most of them go to you guys, yeah, obviously, the first thing you want to do is take a very good and accurate history. Nine times out of the 10, people who come to me with a tear of their labrum, it's not from one particular injury. It's usually an insidious onset of pain, usually repetitive movements or activities. So obviously, you want to get an idea of how long the pain's been going on, what activities they like to do if there was an injury that started the pain. But one of the important questions I always ask them is I ask them to, if you can point with one finger to where your pain is, can you do that for me? And that's a very important point because there's this thing called a C sign, which I like to use. Because if I
Hmm.
ask them that question, and let's say they take one finger and they like point it to like, like you said, like the side of their hip or in the back of their hip, like in their lower back. People don't know what the hip is. They think their hip is like the right side of their lower back. It's nowhere near, where the labrum is. But
Sure.
in the patients that they kind of have difficulty pointing with one finger, they'll take their hand and make a C with their hand and kind of stand up and they kind of put their hand, I'll try to stand up so you can see, they'll put their hand
Yep.
around their hip like this. Okay. And so it's sort of like a deep pain that they're describing that they can't really sort of touch on the surface. So that's a good first clue that whatever's hurting them is it could be an intra-articular etiology.
Okay. And and from there, will you go for imaging right away? Special tests? I assume that you have the patients in your office. They're seeking your help to get rid of their hip pain.
Yeah.
And what's your next step with that patient?
Yeah, just a few other subjective complaints that they may have. I like to ask specifically if they have any mechanical symptoms in their hip, clicking, catching, snapping, popping, all of that stuff could be a sign of labral pathology, or it could even be an extra-articular source, such as a snapping hip, like your iliopsoas tendon snapping. Um, Physical exam obviously is paramount in these patients. I would say the most important physical exam finding that I like to use is the impingement test. But
Hmm.
we go through range of motion, and I'm looking for signs of impingement. So if I flex their hip up and this recreates their pain, internally rotate their hip, that recreates their pain. The impingement test is basically a combination of those two plus adduction. So I'm flexing up the hip, internally rotate, and then I bring their hip across their body. And people who have true impingement they really
Okay.
feel the pain there. So That's an important physical exam finding. You also like to talk about the iliopsoas tendon and pathology there. I
Hmm.
always like to look for snapping of the iliopsoas tendon. So how I determine that is I'll take their hip up, flex it, externally rotate the hip, and then bring it to an extended position. And if you can feel like a reproducible snap or a pop in the mid portion of that range, then that makes me think that there's also iliopsoas tendon pathology, which may need to be addressed arthroscopically as well.
Okay. Now, I know that we didn't teach you those tests at NISMET where you did your fellowship. Did you learn them in medical school at Penn State, or was that residency at Stony Brook?
First of all, college was Penn State.
Were
I
you
went,
were you played free safety or was that cornerback?
yeah, so yeah, I know one of your previous guests was a free safety. I will say that I was a pretty damn good intramural softball player, though. Okay,
Nice.
so yeah,
All right.
I think we lost in the championship in the fraternity league, so that's nothing
Awesome.
to sneeze at. Um, but no, so as you know, when I was at Lenox Hill, which
Yeah.
was almost 17 years ago, I can't believe I've known
Long
you for that long, by the way.
20.
Almost, that's right. So it's crazy. As you know, there was nobody there doing
No.
scopes. There was no Baram wasn't there. Dr. Galano wasn't there.
No.
And in my residency, nobody did hip arthroscopy either. So I got absolutely zero training in hip arthroscopy through medical school, residency, and fellowship. So I took this job at Somers Orthopedics, which is
Hmm.
we're like in northern Westchester, Connecticut, Hudson Valley area. A lot of impressive surgeons up here. I got up here thinking I'm like, oh, I'm the sports medicine guy, trained at Lenox Hill. Found out quickly everyone pretty much did the same stuff that I did. Our joint replacement guys were all doing ACLs. We were all doing complex arthroscopic shoulder stuff. So I realized I had to do something to kind of to set me apart. The one thing that we were not keeping in the group were our hip arthroscopy patients. So people who needed hip scopes were getting sent down to the city to see a specialist who basically all they did was hip scope. So I thought that was a good opportunity for me to sort of learn that technique, but I had to fully do it myself. I went down, I learned from Thomas Bird. I took a couple of courses from him, did cadaver labs with him. I mean, as far as I'm concerned, he didn't invent hip arthroscopy, but I think he pioneered the modern techniques that are still being used today. So I took courses with him, cadaver labs, started doing some cases. And that's the hardest part is when you're starting to do some cases. Usually when you're first starting out in practice, you like to have for more difficult cases that attending presence, that senior guy with you to help you along in case you get into trouble. Well, I didn't have anybody like that up here at all. But I would still ask, one of the guys that started the group, Dr. Buckhalter, who I think you know, uh,
I do.
he a tremendous surgeon, but he's a joint replacement surgeon. I asked him, "Do you mind scrubbing with me for the first couple of these?" He's like, "Yeah, absolutely." I'm like, "Have you ever done this before?" He's like, "No, no, not at all." I'm like, all right, but do you mind scrubbing anyway? He's like, sure. So I would do the cases, and he wasn't really too much help, physically, but he was behind me, sort of being like, "You're doing great, Scott. Keep going." It was just good to have that moral support there, just to give you the confidence to keep going. But like anything, it's a very steep learning curve. Uh,
Hmm.
the more you do, the better you get, and eventually, I kind of sort of developed a little niche with that. So that's how it all
Um,
started.
17 years ago, when you started at NISMAC, I was actually seeing some of these from other surgeons across the country. And what was very funny is that there was a lot of failures, because they would do a hip scope on every every hip that walked through the door that had pain. So
Right.
can you talk a little bit about that and how maybe the patient selection, especially with the amount of OA, predetermines the outcome sometimes?
Absolutely. So first thing to understand that a lot of patients don't get is just how common it is for an MRI to show a tear of the labrum.
Hmm.
There was a study done in AJSM back in 2012 where they took a bunch of patients who had absolutely no hip pain at all, completely asymptomatic, got MRIs on those hips, 3T MRI, so it's a good high detailed MRI. 69% of those patients came back showing a tear of the labrum. So just right there shows you that just having an MRI which shows a tear of the labrum is not an indication for surgery. So that's one problem. I get a lot of referrals from primary care doctors in the area who a lot of times they don't even get x-rays first. They just go right to an MRI on patients with hip pain. And of course it shows a tear of the labrum. They get sent to my office to be fixed, to have surgery. The patients are coming to my office expecting to have surgery. I'm looking at, I'm asking the patient, why are you here? Well, my MRI shows a tear of the labrum. I'm like, all right, well, what did the x-ray? Did they do x-rays? No, they never did x-rays. You get an x-ray, they have like bone-on-bone arthritis. They
Right.
have cysts in the femoral head and the acetabulum, completely not a candidate for hip arthroscopy. So the most important thing is making sure that these patients really do need a hip scope. The things that I like to use to determine how much arthritis is too much arthritis is obviously you start with x-rays. There's a grading system called the Tönnis
Hmm.
system. So it's 0, 1, 2, or 3. 0 is basically no arthritis. 1 is slight joint space narrowing and small osteophytes. 2 is more moderate joint space. 3 is like bone on bone osteophytes, cysts. So basically, if you have a patient between 0 and 1, those people can benefit from hip arthroscopy.
Okay.
Beyond that, they're onto a hip replacement. But even as important as x-rays, what I really like to look like if I have a patient that's on the borderline between a hip scope or a total hip, I like to do an MRI, and specifically I'm looking for subchondral cysts in the acetabulum. Okay, that's
Okay.
that's a very, very important one. If the MRI shows that there's subchondral cysts in the acetabulum, that's a sign of full thickness cartilage loss on the acetabulum, and that's pretty much an absolute contraindication in my practice to do the surgery. So
Okay.
that's the most important thing.
Outstanding.
Yeah.
What about a patient that has a loss of pre-op range of motion or strength? Will that affect your outcome? Will you not operate on that patient, or what will you do with that patient?
Well, if a patient has really decreased range of motion, or if they're in like a significant amount of pain when I'm moving their hip around, it kind of clicks in my mind, well, what's causing this patient to have such poor range of motion? Is it a mechanical problem? Is it because they're having such impingement that
Mhm.
once I flex their hip up to only 70 or 80 degrees, they're already having pain? Then then I think they're still a good candidate. Um, the one patient, the patients that I do worry about are sort of like the more dramatic patients, anxious patients, um, patients with depression. They've done, there's a lot of literature out there that people who have anxiety and depression tend to do very poorly with hip arthroscopy and with most surgery. So when I'm moving a patient's hip around and they're in and it's stopping to a point, um, because it hurts, I have to figure out, is that real pain or are they truly impinging? As far as preoperative strength is concerned, honestly, I don't put too much into that. I like to do like a resisted straight leg raise test on patients, just to kind of see if it causes pain for them, if they have weakness secondary to pain. Um, but that can also be a little bit ambiguous because that could be a sign of either a labral tear or hip flexor tendinitis. Um, but honestly, I don't put too much into a preoperative strength when I'm deciding, who is a candidate for hip arthroscopy. The one thing I was thinking about was, like as you know, when we do ACL reconstructions, we like to try to, as much as possible, try to get back as much range of motion as possible or build up their strength if we, quadricep strength. Um, I don't really, that's not something we do as much in hip arthroscopy. It's not like I don't
Mhm.
feel it's as important to prehab hip arthroscopy patients.
Okay, that's That's excellent. Thank you. Yeah, we deal with a lot of the psychosocial components of the patient's post-operative care quite often, actually.
Yeah,
And
you can always tell, like you really can just get it. I'm sure you can also. You can really get a feeling for which patients are going to do well and which patients aren't, just
yeah,
from their personalities, you know?
and there are outcome scores that are available. The Tampa Kinesio score we use. We use some Harris hip scores, stuff like that, just to get a pre-op post-op gauge of those folks. Now that we've selected our patient, some of the preventing complications during surgery, you know, being a member of ISHA, the International Hip Preservation Society. I've gone to a lot of lectures and listened to the post to the pink pad, or how much traction time, or how much bone should I remove during the FAI. Would you mind delving into some of those areas and talking about that right now?
Yeah, for sure. So, I mean, one of the things about hip arthroscopy is it really introduces a whole new set of complications that can happen during surgery.
Hmm.
Um, the hip is a very deep joint. The acetabulum is very deep. The ball and socket, there's a lot of surrounding soft tissue. There's a lot of nerves, surrounding the hip joint. So just from getting access into the hip joint, there's so much that can go wrong. Um, so as you know, we have to pull a tremendous amount of traction across the hip in order to,
Hmm.
open up the hip to create a space so we can put our instruments in there and do the things that we need to do. First thing you brought up was as far as gaining traction, there's either you can use a padded post, or the pink pad, which I'm not sure if the audience is
Yeah, can you go
yeah.
over that first, please? Thank you.
Sure. So yeah, the post is basically it's a very big padded post that goes into the groin area, basically, that
Hmm.
basically provides some counter traction as we're pulling the hip at the foot. We're pulling
Yeah.
traction across the hip. You need some sort of counter traction to open up the hip. It's a lot of padding, which is good. So it decreases the risk of pudendal nerve palsy. Okay. However, certain patients are more difficult to gain traction with. Uh, and in those patients, I like to use what's called the pink pad. So mostly, I really use the pink pad predominantly for males, especially like young, very muscular males.
Yeah.
What the pink pad is, and this always blew my mind how this would even work. I could never understand how you could possibly get traction from just pulling on the leg with nothing to pull against. But the pink pad is simply it's a pink foam pad that just happens to have a lot of friction. And you put the patient on there, and just the weight of the patient on that pad, it basically like acts like stickum almost. It'll hold that patient there. Some people like to do the technique of doing Trendelenburg on
Hmm.
the bed to tilt the patient back to put a little bit more weight on the pad.
Okay.
But I've found that you don't even need to do that anymore. You you just put them on. You put the foot in the traction device and you pull across, and it works. You know,
Wait, you're putting the foot in a traction device. You're not grabbing the ankle down at the calcaneus and pulling it and then placing it on the pink pad and it stays there, or no?
no, we put the
Okay.
patient on the pink pad.
Yeah.
No traction. I'll put the foot in this boot that's on a traction device.
Okay.
Crank that, pull as hard as you can, strap that foot in, and then manually, like with my hands and my big strong biceps, pulling as hard as I
No, you're
possibly.
a safety, not a defensive end. Come on.
That's right. Fine, fine.
Mhm.
Pulling as hard as I can to get traction, and we have a fluoroscope over top,
Okay.
and I can watch it open up. When I first started doing these, the pink pad was, I mean, I'm sure it existed, but it wasn't
Yeah,
very.
we didn't have it.
We didn't have it. So I'll never forget that I had a couple of pudendal nerve palsies. One was a 28-year-old police officer, big,
Oh,
strong, muscular guy. I remember in the first post-op appointment, like 7 days after surgery, walk in. I'm like, "Hey, how you doing?" He's like, "Oh, I'm doing okay, I guess." I'm like, "Oh." I'm like, "Are you having a lot of pain in the hip?" He's like, "No, actually, my hip feels good." I'm like, "Well, what's wrong?" He's like, he's like, I'm feeling like some numbness. I'm like, oh, I'm like the foot or, where are you numb? He's like, no, he's like actually in my, genitals.
Magic Winky.
Yeah. Yeah. And
Yeah.
I was like, okay, this is the first I've heard of this. I've read about this, but this is
Yep.
happening now. So a reassurance, it's going to get better. There was compression of the pudendal nerve on the pad. We didn't transect the nerve, so it's going to come back. And he's like, yeah, my wife is just concerned because I can't get aroused and the whole thing. I'm like, okay, it'll be
Oh
fine.
gosh.
So I'm like, all right, it's going to resolve. And me and my on the back of my mind, I'm like, holy, I hope it resolves, right? So,
Yeah.
and then the next appointment comes. It's 3 weeks later. I see the patient walk in, and the wife is with the patient this time. And I'm like, oh,
Oh,
gee, like
oh
that's,
my.
yeah. I was like, this is not good. So I go in, and he's still having the problem. And I'm telling you right now, the wife was not happy. She was she was not happy. But I just had to like calm her down, reassure her
Yeah.
everything's fine. And thankfully, a couple of weeks later, it did resolve and everything is fine. But ever since then, I started looking into the a way to get
The
post-list
pink pad.
surgery. And the pink
Yeah,
pad
yeah,
has saved me. So
yeah.
any young muscular male, I use
Yeah.
the pink pad.
You haven't had. You don't get it with the pink pad, correct?
No,
Right.
you can't get that. You can't get the pudendal nerve. You can still get traction injury to the nerves because
Right.
you're still pulling the hip apart, but you
Yeah.
can't get that pudendal nerve palsy. So
Thank you. That was really informative for me. I appreciate that.
yeah.
Excellent. Um, Go into bone removal. So if you have an FAI and you have loss of range of motion, one of the things that when I see FAI patients preoperatively, I like to see how much hip flexion they have and measure their hip flexion on their back, do side to side difference, and take a look at that and get a subjective also. Do they have pain at this certain range of motion? Usually it's somewhere around 135, 140 of hip flexion as I bring it up passively, right?
Hmm.
So, but when after you guys do the surgery and you take enough bone, because I've seen surgeons who don't take enough bone and they have the same symptoms. So it's kind of the art of medicine and surgery, but it seems to be changing according to some of the recent lectures I went to. Can you talk about taking enough bone and that complication
Yeah.
interoperatively?
For sure. I can tell you without a doubt when I first started doing these, and first started doing camera sections, I was not taking nearly enough bone. Because it's kind of scary. You're in the hip, you're around the femoral neck, at the femoral head neck junction,
Mhm.
you're taking a burr, you're literally burring down this bone, knowing all full well how many hip fractures I've had to fix in my life before
Yeah.
that, and knowing this is the bone that I'm having to fix, and here I am literally taking this bone away. Uh, and so I would get post-op x-rays and be like, oh, did I even do anything? So definitely under resection. And I think you made the perfect point. I think under resection is the biggest problem and the biggest reason why patients have to go back to have things done. And I've definitely done it. I've definitely not taken enough bone. And you know, honestly, addressing the labrum, it's important. It's not nearly as important as addressing the bony issue. You can do a perfect labral repair,
Mhm.
2, 3 anchors, reattach the S-habum. If you don't touch that bone, the patient will feel great for a few months, maybe even a year. If you don't take away the bone that caused that tear in the first place, that
Yep.
patient's gonna be back in your office sooner than you think. So, um, but it's difficult. It really is difficult because when you're resecting bone, you're arthroscopically, you're looking and seeing what you're doing, and you're looking, you have a fluoroscope there also, so you can kind of see how much you're taking there. But you got to remember the fluoroscope's a two-dimensional X-ray. It's not like
Hmm.
a three-dimensional like CT scan. So it is, and it's still hard. It's still hard to really get a good feel for um, how much bone to take. But I've definitely been a lot more aggressive with taking more bone. If you do a really good camera section, you will see those patients that you saw like preoperatively, and you move them. I just did. I had a 16-year-old girl who had a cam lesion, terrible pain at 70 degrees. I couldn't flex her past 70 degrees because of pain.
Wow.
I went in there. She actually didn't even have a tear of the labrum yet. It was just hyperemic and red,
Hmm.
maybe a little bit frayed, but no chondrolabral detachment. I just did a really nice camera section and post-operative, first post-operative appointment probably gained 40 degrees already right from the beginning, and she had no pain. She said right away, I can feel the difference in my range of motion. So it's very, very important to make sure you're resecting enough. But it's scary at the beginning because you do see like some nightmare cases of like video, like surgical videos you're watching where there's like a big divot in the neck and there's like a little bit of neck left. And I mean, my biggest fear, the fear of all fears, is causing a hip fracture in these patients.
Yeah.
So that's hard. That's a hard fear to get over. So I still think about it.
Thank you very much. Before we go into your post-op protocol and some of the early weight bearing range of motion and and bracing and sleeping, Rob, are there any questions? Do you have any questions yourself or Donis? And also, are there any questions from the audience for Dr. Levin?
I don't see there anything now, but I'll
Okay.
keep looking. What's your thought on conversion rates? Like how many of these patients will go on for a total hip? That was always one of the arguments. Like, hey, do we do preservation? Will they go on for a total hip? Does it make sense
Yeah,
or not?
it's that goes back to the point we made at the beginning with making sure that you have the right patient selection. If you go in there and you see full th or grade 3 or 4 changes, that patient will undoubtedly go on to a hip replacement probably within 2 years. Um, and that's the most important thing. And the other thing I can't stress enough is um, people can really develop arthritis very, very quickly. If I see a patient and, let's say I saw him like a year before and the x-rays at that time looked fine, and then they come back to me and they're still having pain, before I take them to the OR, I get another X-ray. Even if it was only 6 months ago, I'll get another X-ray because I have seen it where in a matter of months their joint space just collapses
Wow.
and they have bone-on-bone arthritis. Especially if you're dealing with a patient. A lot of patients like to get cortisone shots. I like to try to minimize the cortisone injections in the hip. I'll do one mostly to diagnose the problem, just to make sure that, or at least I'll do an injection of a Marcaine or an anesthetic, just to make sure that the pain that they're feeling is intra-articular in nature. But if you're dealing, some of these patients have been elsewhere and they've had like 3 or 4 cortisone injections, you got to really be careful with those patients of developing like rapidly developing arthritis in the hip. So I always get one final X-ray if I haven't had one in like 6 to 12 months, just to make sure that they didn't develop arthritis in the interim.
Yeah. I always find it, yeah, hard by looking at their joint, like their patterns. We always have the C sign, but then you have your patients with knee pain or hip and
Right.
lateral hip. Is it a bursitis? Is it that? So it's one of
Yeah.
those. So
And
you think
the
injection is probably
yeah, that's a
your best?
diagnostic injection. In fact, I do have maybe 30% of patients will have like an atypical presentation of hip pain. So
Hmm.
it's not always in the groin. Sometimes I'll see patients with like sort of vague lateral hip pain. I just saw one today actually. Lateral hip pain, kept on getting bursitis injections, didn't really do anything. Or posterolateral hip pain. You do an injection in the office. We do it right in our office under ultrasound guidance, and you see how they respond. You'll be surprised how many of those patients, that lateral hip pain that they have goes away with an intra-articular injection, and that's like a really good indication that those patients might benefit from a scope.
Right. Even seeing patients, SI joint patients get groin pain. That's why it's such a
Yeah.
tough.
It's hard. It's like I said, it's like the surgery is hard enough, but it's just as hard to pick the right patients. I mean, you'll see patients with they come in with an MRI with a tear of the labrum. I examine the patient. This patient has an inguinal hernia, and that's what's
Hmm.
causing their pain. You send them to a general surgeon, they get their hernia fixed and their pain's gone. You could have done an operation on that patient, fixed their labrum, they would have woken up, still had the same pain. So you're not doing that patient any favors.
All right. Do you weight bear your post-op FAIs and labor repairs or debridements full weight bearing right away? And do you use a brace like some of the surgeons around the area?
So first of all, with the brace, I've never used a brace. I just find that to me, like seeing what those braces look like, I can't imagine patients tolerating a brace. It's bulky, it's uncomfortable. I just didn't never found it necessary. But I went to a conference. I went to AOSSM meeting this a couple months
In,
ago
in Nashville.
in Nashville. Yeah, and there was a podium presentation about bracing, and I was very happy to hear that bracing made absolutely no difference.
Out.
Yeah, so that made me feel like I was doing the right thing. So I don't use a brace. So about your weight bearing question, that was you know, when I read your article that you sent to me, it was I really liked it because it kind of sort of justified some of the things in my mind that I always thought about that, you know, right now, when I have the post-op patients, no matter what I do for the first 7 to 10 days, I have them on crutches with toe touch or foot flat weight bearing until I see them in the office. And at the first post-op appointment, if I just did a debridement and like a camera and a camera section,
Mm-hmm.
I'll have them put full weight on it at that point. But because of the camera section, I'll still use crutches just for fear of if they were to trip and fall, they have that support because I'm paranoid about the hip fracture, femoral neck fracture. If I
Right.
if I just did a debridement and a like a pincer or iliopsoas release,
Yeah.
then I get rid of the crutches basically at like a week, 7 to 10 days.
Right.
If it's a tear of, if I did a labral repair, I'll have them on crutches for 4 weeks, but I'll let them be partial weight bearing, 50% partial weight bearing on the extremity. But the why did I do that? Because that's the rehab protocol I got from Bird, basically. It
Yeah.
was no, I wasn't doing any that you guys are you're the academic guy, you're doing the studies, you're doing the research. So there's really nothing to it other than that's what I've always done. But I always feel like, half these patients I see them in the first post-op appointment, they have their crutches, but they're holding it in their hand and they're just
I
walking.
know. Right.
Yeah, it's like I'm like, why are you not using crutches? They're like,
I think
I
that's
don't see
partially.
any difference. Yeah.
I think that's partially on us as physical therapists, and Rob, you can speak to this too. But I think that we need to encourage our patients to restore their gait, their normal gait, before we remove the crutches. Teach them gait training,
Hmm.
how to walk, how to weight bear evenly. The whole gamut of there, heel toe and full weight bearing before. So get them walking normally on the crutches, whether it's a knee, a hip, or an ankle surgery or non-op treatment. Rob, what's your feeling on that?
No, I 100% agree. I think it's gone by the
Yeah.
wayside. I think it's back, quote unquote, the old school thinking.
Yeah.
But I
Yeah.
don't like to get people off of stuff, even if more for the purpose of just getting a bad gait pattern. You take 3 weeks to become a habit, and we let
You got
them
to
do
break
it. And
that.
it's
You got to
just
break that premotor cortex. You got to break that
agreed.
motor program. So I'm now, Doc. We're totally spending time breaking that motor program because
Yeah.
they're circumducting. They're hip hiking, and
Right.
and
And then
it's
the other point is, you mentioned the problem of iliopsoas
yeah,
tendinosis after surgery.
yeah.
You're that patient spending so much time trying to keep their weight off the leg, they're probably irritating their iliopsoas
It's
tendon.
They're
That might be the
activating
problem right there,
Yep.
constantly,
Yeah.
constantly.
But it also goes back to, hip arthroscopy. We've been doing it for, a few years, 20 years or so now, more popular, but it's definitely it's a relatively new procedure compared to, other surgeries like ACL surgery. If you look at the history of ACL surgery and rehabilitation, look how they used to do in the 80s.
Oh yeah,
My father-in-law had his ACL done. He told me he was in a cast for 2 months.
I remember
yeah.
that.
And
Yeah.
he got the cast off, and yeah, his knee was stable, but he also couldn't move it, and he had tremendous atrophy. So, and now I think it's the same thing with hip scopes. We are so afraid of whatever, breaking the hip or breaking having the repair fail that we have patients on crutches for 4 weeks, minimizing their weight bearing, and we're probably doing more harm than good. So that's why, reading your paper was good.
Probably. I mean, we don't restrict the range of motion at all. Do you?
Um, Once again, for the first 4 weeks, for no other reason other than this is the protocol I've always used.
Yeah.
I limit hip flexion to 90 degrees and I avoid external rotation for the first 4 weeks, but
Hmm.
probably unnecessarily.
Yeah. Or the one thing I'm adamant about, if there's any therapist on this call, is that the straight leg raises in supine is the kiss of death for this surgery. Okay. Because
Foremost. Mhm.
the number one complication for a hip scope is iliopsoas tendinosis. I, I saw 3 of them this summer that were going other places from other surgeons, and it was like, really? So now they've set themselves back 4 to 6 weeks, and no, avoid that. If you want to do, you can do isolated iliopsoas strengthening, submaximal in a neutral position, 90 degrees of flexion, pain free, isometrics, and progress to different range of motions.
What about what about, like, because one thing that's on my protocol is I have
Yeah.
them do within the first few weeks where they're standing and they flex their hip up from a standing position, flex it forward. So it's not too much stress. What do you think about that?
I think that's fine, but I wouldn't do it as an exercise too often. But they're going to need to do that to walk. So
Right. Yep.
that motion needs. I don't think they need to strengthen that, but they definitely needed to get that range of motion available to get their to clear their hip and get their foot from catching the floor or the ground as they ambulate.
Right. So so your protocol now is basically you allow full weight bearing from the beginning,
Yes,
no restrictions in range of motion?
none.
None. Okay.
Rotation. We don't go for passive hard passive range of motion early on. We back off there till 4 weeks. But actively, yeah, stool rotations, things like that, 100%. Yeah.
Yeah, great.
And
Like
and some of our pro athletes and high level athletes, remind you, are getting 3 surgeries at once. They're getting a FAI. They're getting a labral repair, whether it's a partial or total 360 circumferential.
circumferential.
Yeah, that word. And then they'll get maybe and then they'll maybe get a sports hernia repair the posterior wall of the ankle canal while they're doing that surgery too. So yeah, there's a lot of things going on there that we need to tease out.
That's
So
great.
um, let's go into the article now. Unless Rob, do you have any other questions or points you want to bring up for Doc?
No, I think we're good. I think
All
we've hit
right,
them all so far.
we'll move to this amazing article.
Mhm.
Yeah, right. So I chose this article with Dr. Levin because I want to talk about returning people to sport and returning people to work and what's safe and what was out there. So prior to this article, the average time for return to play was about 7 months, and then after this article, the average return to competition was about 9 months, and that's what was available in the literature. So we wanted to see if we could push the envelope because people were getting back without the doctor's clearance and saying fine anyway. And these were golfers and hockey players mostly, but certainly we took a look at this in our patient population. We had a total of 56 patients, 22 males, 34 females, and they went through the rehab guidelines, which is seen at the end of the paper. You have all the rehab guidelines there, and we went to see how often they returned and was there differences when they returned. And we broke, but what was unique about this paper is that we broke the athletes down into high demand, moderate demand athletes, or low demand athletes. We had professional athletes, intercollegiate athletes, and we looked at the average durations of symptoms prior to surgery to see if that would make a difference. So the prevalence of symptoms upon return to sport was not different between high demand competitive athletes, moderate demand, or low demand athletes. There's no difference if you were a pro athlete or if you were a high school athlete on return to sport when you returned. The average return for all these folks was let me find that in this article right there.
It was like 5 months or something.
Yeah, 5.3 months plus or minus 3.5 months. So we did have some complications. I have to be honest there. We had people who went on to have other surgeries. but nothing was was hip related. One had a hernia surgery, and 4 had unrelated injuries that prevented them from returning to sports. What was interesting too is that the average duration of symptoms prior to surgery was 1 to 1.5, 1.7, 1 year, 7 months. Okay, with a standard deviation of 1.4, 1.1 year, 4 months. Okay, but the duration was not different between the people who returned to sport, okay, and the 12 people who did not return to sport. There was no, if you had it longer, it didn't mean you had a worse result. So that I found that interesting. That was one of the questions that I really wanted to answer. Was like, if I have an athlete that was out longer, I mean, if you wait on the surgery, you're doing more damage. Does it prevent you from returning to sport earlier? And it doesn't. So those are my highlights for that. Once again, I want to bring to your attention that the physical therapy article by Mike Ryman et al. Out of Duke, they showed that the average time to return to sport was 7 months, and now we're pushing our patients to return to about 5 months. Not everybody returns at 5 months, but we certainly can get them back without increased complications to sport at about the 5-month time frame.
I have a quick question actually.
Yeah, go.
Was there the one thing that stood out for me, there's a few things in the article that from what I do, we talked about the weight bearing and the range of motion without limitations. The other thing I noticed was you allow impact activities and running at 2 months or 8 weeks, it looks like.
8 weeks, exactly.
Yeah,
I got
8
it right
weeks.
here.
Yeah. And then and so I definitely delay that for people with camera section to 12 weeks.
Does the extra 4 weeks increase the bone growth and where you resected? Maybe.
I mean, I think it does, but does it make a difference clinically? I don't know. But
Study it. See, X-ray them. Do X-rays. Get them serial X-rays and see if it does. That'd be great.
Yeah, that's like that could be a good.
I'll do it. Forget it.
You have all the fellows and residents there. Why don't you do it?
I will. Don't worry.
Oh, okay.
That's a great question. I will give you credit on that one, though. That's for sure.
Yeah, but if you do an article, you got to at least put my name on it. Throw my name there.
On the article?
Yeah. Well,
as an author?
Well, yeah, like somewhere in the middle. Yeah.
You can be on every paper then. Why not?
Okay. Sounds good. Deal.
Golf. When would you let your patient play golf? Get that question all the time. All right. And does it matter if it's the front foot or the back foot?
It's a very good question. Well, I'll let them work on putting and chipping relatively early, 6 to 8 weeks, I'd say, for chipping and putting. Full swing, I'd let them start doing some light, like pitching at maybe 3 months post-operatively. I would say I never really thought about front foot versus back foot. I mean, to be honest, with both in the golf swing, you're really rotating on both hips.
You're and a hockey player and a golfer though, that your rotational loading on that front leg is a lot more torsional.
Yeah.
As opposed to the back leg.
So do you guys, what is your when do you see high level golfers returning to play if it's their front, especially if it's their front hip?
If it's their front hip, 4 months, maybe later. Okay.
Yeah,
it's all dependent on the symptoms. Okay. We're certainly working there during the rehabilitation process. We're working that front leg a little bit different than the back leg, and we're really making sure we get full closed chain internal rotation motion. Okay. So, but it's definitely based on their symptomatology. That's for sure.
Yep.
Rob, what about you? Do you are you doing back foot versus front foot any differently, or any other?
I would definitely. Yeah, I would think of the front foot because the internal rotation through the pelvis going faster.
Yes.
So we have that increased force in the hip. for the front
Hmm.
foot.
The only
So,
thing I can think of though, also in the back hip, the back hip's also not without some stress because you're
oh
definitely
no, agreed.
you're
I
turning,
totally agree.
you're low, you got a little bit of a flexion in the hip, you're really loading onto that back hip. Probably not as much torsional stress, but a little bit more, maybe more weight bearing stress there,
Hmm.
if you think about it.
Yeah, but if you think about the proper golf swing, they're all the way over. You're in double limb stance in the backswing, okay? But when you come up on through the follow through into the golf swing, the chest is supposed to be facing the target, and all the weight should be on the front foot. So it's a little bit different. So we take that into account when we're rehabbing these folks.
This is great because I'm also getting a free golf lesson out of this now.
My last question for you, Dr. Levin, is what about that laborer who has to who's had that deep hip pain, you've done surgery, you've taken down the cam, and that person is working at Home Depot and they're lifting crates, boxes, and everything, and they have to go from a deep squat and get that back onto the shelf. When do you let that working athlete, if you will, back
Yeah.
to work?
I'm a little bit more aggressive with that patient population, assuming that that patient is motivated to get back to work. By the way,
Sure.
a
Yeah.
lot of these people are workers' comp patients. They don't want to go back to work so quickly. Um, but I would say I try to get them back at like 3 months if I can.
Okay.
Because they're not doing that sort of high impact jumping, pivoting type of thing. It's just kind of more lifting and just as long as they can get that, if they can get their hip flexion back and they're comfortable and they're not impinging, then I try to get them back, at 3 months if I can.
Excellent. Excellent.
Yeah.
Rob, Don, do we have any questions from the audience, or do you guys have any final questions?
What are the thoughts like heterotopic bone? Is that a big, are you seeing that a lot, or is it more of a procedural based thing versus?
I do. I put people on prophylaxis when I do a camera section. I give them indomethacin, 75 milligrams for 5 days. Um, Truthfully, I think I've seen one case of heterotopic ossification in the past like 15 years.
Mhm.
Hmm.
So it's definitely not something I'm seeing a lot of. I still do the HO prophylaxis just in case, as long as they can tolerate the medication. In my mind, it actually helps with their pain too. It's a very strong anti-inflammatory. But anyone I do a camera section on, I'll put them on HO prophylaxis.
All right.
Yeah, we do have one.
Hi, Haley.
Hmm. Do you have any recommendations for patients who have jobs that require long periods of sitting? Any self-mobilizations to the chair, modifications to the chair, sorry.
Yeah, I mean, yeah, I think that's just a matter of sort of ergonomically changing their work environment. I'm a big fan of standing desks. Adjusting the seat so you're minimizing hip flexion. Raising the seat so you're not, you don't have to bend down so much to sit, and also just telling patients to don't sit for hours at a time. Maybe once an hour, get up and walk around the office. So you're taking that pressure, so you're not just sort of leaning with that labrum being compressed in between the two bones for an hour straight. Um, but truthfully, it hasn't really been. I haven't really seen too much of an issue with that.
Yes, but a complaint always is driving. Oh, I'm driving 2 hours to my grandma's house, and I got to be in the car. And I tell them, you know what? Stop every half hour. Get out,
Yeah,
stretch, take long strides.
that's
So, and
exactly what I do if they're going on a flight and get up every 45 minutes, get up and walk up and down the
yep,
plane. Just don't sit in the
exactly.
same position the whole time. Yeah.
Excellent, excellent. Well, you've been great. I really appreciate you getting on the call and doing the sports medicine research rundown with us. If other people want to send their patients to you or that how do we get in touch with you? Can you tell the audience?
Yeah, so I'm with Somers Orthopedics. We're based out of our center is basically Danbury, Connecticut, but we have satellite offices all throughout Westchester and the Hudson Valley. I see patients in Danbury, Mount Kisco, New York, Fishkill, Newburgh, and Carmel. So we're pretty much all over.
Excellent.
If you want to make an appointment, the best way is our main number is 845-278-8400. Or you can go, I have a website. If you go to www.scottlevinmd.com,
Okay.
you can book appointments. Supposedly, you're able to book appointments directly on the website. So
All right.
if that's actually working, then you can do it there.
And if you
I
were-
can help you with that, Dr. Levin. You can also contact Kristen Gross with
I was
Health
just
Plus
going to say
Management.
that.
Great.
Or you can
Yes,
contact
I'm here.
Allison Round. She'll schedule it for you.
Perfect.
Yes,
Thank
or
you.
I can schedule it for you. Yes.
There you go.
Awesome. Thank you.
All right, Doc. Thank you so much, my man.
All right,
Appreciate
Tim.
Appreciate
Great
it.
seeing you again, buddy.
Great
Thanks,
seeing you
Dr.
too,
Levin.
pal. Bye-bye.
Thanks, everybody.
Have a good night. Thank
Thanks,
you.
Rob. Thanks, Allie.